Good afternoon, everyone. For those of you who don't know me, I'm Dr. Ramesh Jois. I'm a rheumatologist in Bangalore. I work at Vikram Hospital, which in the near future will be called Manipal Hospital, Millers Road. And I've been a rheumatologist in Bangalore for the last 13, 14 years. I did my MD from Bangalore Medical College, and then I did my rheumatology training from the UK. So with this brief introduction, I'll take you through in the next 45 minutes about this topic of autoimmunity and infertility. So the most important aspect that one has to understand is that pregnancy in itself is an autoimmune state. So the autoimmune response from the body to a gravid uterus changes with the stage of pregnancy. If you look at the implantation phase, which is the first one here, you will see that it is a predominantly Th1 mediated response. So the Th1 mediated response releases certain cytokines like interferons, TNF alpha, and they're required to regulate the trophoblast invasion and tissue remodeling and angiogenesis. And once the implantation is done, then post-implantation, the Th1 is regulated by something called Treg cells or T cell regulators, and that switches off the Th1 and gets into something called a Th2 response. Now, if we don't have the Th2 response at this stage, the pregnancy will not sustain. So the Th2 activation and the Th17 activation results in a variety of cytokines, and they are important. One, to protect the trophoblast from various pathogens, infections, so on and so forth. And also, as you know, the fetus is a foreign body within the mother. So it promotes allograft tolerance, that is acceptance of the foreign body. And then, post-implantation and late gestation, you have a completely different response. So all in all, to say that there is some degree of natural autoimmunity that is required to sustain pregnancy. And when we say infertility, obviously there must be some autoimmune response that has gone horribly wrong for people to abort or for people not to conceive. And various autoantibodies have been studied in women who are infertile. And there are a whole list of antibodies that have been described in infertility. Starting from antibodies against the zona pellucida, you have anti-phospholipid or cardiolipin antibody, anti-nuclear antibodies, smooth muscle antibody, thyroid antibodies, and so on and so forth. And there's a huge big list like this. So what this tells us that obviously there is some degree of autoimmune response even in infertility, and a lot of these antibodies have been described in infertility. Now, whether these are innocent bystanders or are they pathogenic antibodies that result in infertility is not known with a variety of these antibodies. But however, it has been shown that most of these autoantibodies are in higher proportion in infertile women compared to fertile women. Also, it has been shown that in a variety of diseases, autoantibodies are created. And some of these are examples. For example, in polycystic ovarian disease and endometriosis, you have anti-ovarian antibody, anti-endometrial antibody. For example, in lupus, you have anti-corpus luteum antibody. In men who have had vasectomy or orchitis or varicocele, there are anti-sperm antibodies. So anti-sperm antibody incidence is much higher in men with some form of injury to the testicles. Then there are various other autoimmune diseases like type 1 diabetes, hypothyroid, celiac disease, and others where antibodies are produced and the incidence of infertility is much higher. So all this suggests that even infertility, there is some form of autoimmune response, and whether modification of this autoantibodies results in successful pregnancy is the main story of today's talk. We know that infertility can be primary and secondary. Now, I'm a rheumatologist, so I will not be dealing with primary infertility because a lot of those are associated with gynecological stuff. So I will not go into that. And my talk today will focus more on secondary infertility, or in other words, recurrent pregnancy loss or recurrent miscarriages. So when can you call? Because all of us know a primee, many a times a proportion of preemies abort their first pregnancies. So it is wrong to over investigate young women who abort once. So when should you investigate? So recurrent pregnancy loss has been defined by many international organizations. The problem is in India, due to patient anxiety and due to doctor anxiety, many a times unnecessary investigations are carried out even for primees who abort um, the first pregnancy itself. However, where finance is a consideration, for example, the NHS in the UK, where the government funds every investigation, they are very particular on who should be investigated for infertility. So the Royal College of Obstetrics and Gynecology, RCOG, defines recurrent pregnancy loss as loss of 3 or more consecutive pregnancies, which could include even biochemical pregnancies. Similarly, other European societies like the German, Austrian, or Swiss societies also label it as more than 3 consecutive losses. The American Society for Reproductive Medicine says this is 2 or more failed clinical pregnancies. And the word clinical is important because here they exclude biochemical pregnancies, and the clinical pregnancy has to be confirmed either on an ultrasound or a histological confirmation. So the definitions might vary, but I think most important is one should not have the knee-jerk reaction to start investigating recurrent pregnancy loss with the first miscarriage. Um, Amongst the most widely recognized cause of recurrent pregnancy loss, which a rheumatologist deals, is antiphospholipid antibody syndrome. So the first part of my talk will focus more on antiphospholipid antibody syndrome and connective tissue disease that can cause recurrent pregnancy losses. And the second part of my talk will involve a lot of the latest concepts about investigations and treatments. So when antiphospholipid antibody occurs in the context of an underlying disease, it is called secondary antiphospholipid antibody syndrome. And the commonest example of that is systemic lupus erythematosus, or SLE. Antiphospholipid antibodies are also described in various other rheumatological diseases like rheumatoid arthritis, scleroderma, polymyositis, and so on. But their clinical relevance in this particular condition is not great when it comes to obstetric outcomes. When antiphospholipid antibodies occur de novo without any underlying connective tissue disease, the condition is called primary antiphospholipid antibody syndrome. So when do you say someone has got antiphospholipid antibody syndrome? This is called the antiphospholipid antibody syndrome classification criteria, which were put across by many experts throughout the world, predominantly from Europe. And they said that to classify, this is not a diagnostic criteria. Please note, there is a big difference between diagnostic and classification criteria. So diagnosis is different and classification is different. So to classify as somebody to have antiphospholipid antibody syndrome, one, there should be a history of thrombosis. Generally, the thrombosis could be in the form of arterial thrombosis, and the commonest of it is stroke or TIAs. Sometimes you could have coronary thrombosis, especially in young people. When you see with coronary thrombosis, you have to look for antiphospholipid antibody syndrome. The thrombosis could be in unusual situations like mesenteric pulmonary, extremity in gangrene, small vessel thrombosis resulting in gangrene of the digits, and then rarely even retinal artery thrombosis. When you see a DVT or a venous thrombosis in an unusual location, always think of antiphospholipid antibody syndrome. For example, if you see a brachial vein occlusion or an axillary vein occlusion, which is unusual in people, always think of APLA. And the thrombosis can occur in various other locations like a conventional DVT, a cerebral venous thrombosis, pulmonary, retinal vein, IVC, renal, so on and so forth. The other important part of antiphospholipid antibody syndrome is pregnancy outcomes. So when can you define the pregnancy outcome as? It should be either one or more late term spontaneous abortion. And the definition for a late term is more than 10 weeks. Or if it is before 10 weeks of gestation, it has to be three or more unexplained consecutive spontaneous abortions. And this should not be explained by any chromosomal abnormalities or maternal, anatomical, or hormonal causes like a septate uterus or whatever, numerous other reasons. So it's very important to understand these definitions. And also, the third part is a one or more premature birth of a morphologically healthy neonate at or before 34 weeks of gestation. So if you have almost, coming to term and then you have early fetal death, if it is especially due to severe preeclampsia, eclampsia, or placental insufficiency, even if there is one such incident, do suspect antiphospholipid antibody syndrome. Late pregnancy losses, even one, but very early pregnancy loss before 10 weeks of gestation, the definition at least says three or more. And in addition to these comes the laboratory criteria. There are three antibodies that we rheumatologists request. One of them is called lupus anticoagulant. The other one is called anti-cardiolipin antibody. And the third one is called anti-beta-2 glycoprotein 1 antibody. Now, three important points about all this. When we call as anti-phospholipid antibody, when I see a lot of people writing a prescription, they would say APLA antibody screen. If a lab is going to do an APLA antibody screen, they should be doing all the three, because all these three antibodies are called anti-phospholipid antibodies. But unfortunately, most labs will only understand this as anti-cardiolipin. So they both have been almost made synonymous. So when you write a request for anti-phospholipid antibody, only the cardiolipin gets done. So that's why it's very important to write all the three names. And when it is not just about the presence of antibody positivity, but also the titers. So you have to have the titer moderate or higher. And what is moderate or high? More than 40 GPL or MPL. G is for the IgG and M is for the IgM. Similarly, anti-beta-2 glycoprotein 1 in high titers. So one of the prerequisites is presence of the antibody. The second prerequisite is presence in moderate to high titer. And the third prerequisite would be that if somebody has never had a thrombosis, somebody has had only miscarriage, you found one laboratory test mildly positive, then you should reconfirm that by repeating the test at least 12 weeks later. On the other hand, if you have somebody with already a previous history of thrombosis and one antibody is positive, then you don't have to do two tests mandatorily to treat that person. So to classify somebody as having antiphospholipid antibody syndrome, you have to have at least one clinical criteria, which is either thrombosis or obstetric outcomes with one of the lab criteria. That makes it a definite antiphospholipid antibody syndrome. And that is why it is important to remember all these three things. Why is antiphospholipid antibody so important? That is because it is heavily prothrombotic. So as you know, most of you who are practicing, you will know that to request these three tests, the patient has to spend something around 15,000 rupees. So if you tell me my patient doesn't have so much money, if you want to put your money on any one antibody, and which one would I choose? If you ask me that question, the first antibody I would request is the lupus anticoagulant and not anticardiolipin antibody, because lupus anticoagulant is the most powerful predictor of thrombosis, and it causes a 40-fold increased risk of stroke and a 5-fold increased risk of MI infarction and an increased risk of recurrent miscarriages. So the most important powerful prothrombotic substance is the lupus anticoagulant. Next in the list comes anticardiolipin antibody. So if you are fund crunched, you can do these two. And amongst the anticardiolipin, the IgG type is more strongly associated with clinical events. And then finally comes the anti-beta-2 GP1. Now, if out of these three, if two are positive, certainly the risk of thrombosis increases. But if all the three are positive, these are the patients who are at the highest risk for arterial or venous thrombosis and also obstetric events. So triple antibody positivity puts somebody at the highest risk, and next comes double anti-positivity. So that's why when we look at, when you send us these reports, somebody's got an anti-cardiolipin of 46 IgG, that's all. And you ask me, is this responsible for the recurrent miscarriage? We do something called risk stratification. And what is this risk stratification? We divide patients as high risk group, moderate risk group, and low risk group. What does high risk group mean? A positive lupus anticoagulant test with or without a moderate to high titer of anticardiolipin or anti-beta to GP1, either IgG or IgM. Moderate risk profile would be the lupus anticoagulant is negative, but the other antibodies are in moderate to high titers. Low risk will be the lupus anticoagulant is negative, but the titers of other antibodies is also very low. So it is not mere presence, but also the titers that are important. It's very important that, like a lot of autoantibodies, antiphospholipid antibody can also be seen in normal people. So it can be found in 10% of the healthy blood donors. And that is for anticardiolipin antibody, and 1% positivity for lupus anticoagulant. And when you repeat the antibodies after a year, less than 1% are still positive, which means to say that transient autoantibodies are very common after many things, sometimes even a viral infection. And a lot of these autoantibodies we are seeing, especially after COVID of late. So false positive lupus anticoagulant may also occur in patients on warfarin, heparin, or direct oral anticoagulants. That's why whenever you send a blood test for lupus anticoagulant, the patient should not be on any of the blood thinning drugs like warfarin or heparin or any of the newer anticoagulants. Aspirin and clopidogrel is okay. So that's why a sample has to be quickly sent before anticoagulation is started. Otherwise, there's always a worry of false positivity. So presence of antiphospholipid antibody in connection with lupus is seen in about 30 to 40% of patients. But not all lupus patients who have antiphospholipid antibody develop thrombosis. So if there are 100 lupus patients with these antibodies, only 40 of them develop thrombosis. But that's still a big high. So it is important to understand that lupus, nearly 40% of patients develop thrombosis. And that is primarily because of antiphospholipid antibodies. You look at obstetric literature, you look at studies which have looked at women with recurrent miscarriage and look for prevalence of antiphospholipid antibody in them. Nearly 10 to 15% of women with recurrent miscarriage are APLA positive. Likewise, if you look at the preeclampsia series, it is about 11 to 29% of women who are positive compared to 7% in the control. So from population-based studies, it has been shown that presence of these antibodies increases the risk of preeclampsia and placental insufficiency. And also, if they have had only recurrent miscarriages now, they are at an increased risk of subsequent arterial or venous thrombosis. And that's why these patients have to be kept under follow-up and not discharged after delivery. So coming to obstetric EPLA, which is of more importance to the current meeting or today's meeting, the PROMISE study showed that lupus anticoagulant is the main adverse predictor for pregnancy outcomes. And poor obstetric outcome is also high if a woman has already had a previous history of thrombosis. Then finally, one clinical syndrome you should be aware which can occur along with antiphospholipid antibody syndrome is something called HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelets or thrombocytopenia. Fortunately, it is rare, and the peak frequency is about 27th to 37th weeks of gestation, but it can also occur within the first 48 hours postpartum. So some of the big problems are risk of renal failure and pulmonary edema, severe maternal complications like abruptio placentae, DIC, diffuse intravascular coagulation, postpartum bleed, cerebral events, and others. one series which looked at 442 pregnancies put the maternal mortality out of HELP syndrome at 1%. So if 100 women develop HELP, one of them might die. So obviously one has to be careful when you deal with these patients. So coming to the management of antiphospholipid antibody syndrome. So you have somebody with antiphospholipid antibody syndrome. What are the factors that you look at before deciding on treatment? So one, is there a previous history of thrombosis? That's why I put it in the center, because that's the core. Then when you look at thrombosis, is it an arterial thrombosis or a venous thrombosis? Because they both have different meaning. Then is this the first thrombosis or is this a recurrent thrombosis? Recurrent is on treatment with anticoagulation or without anticoagulation. Is this occurring on the context of lupus or non-lupus patients? Then what is the antibodies that is positive? Are we looking at triple antibody positivity, double antibody positivity, single antibody? Is it persistently positive? Is it moderate to high in titer? All these things. And then there is something called sort of second hit phenomenon in immunology, where you have the predisposition, but an outside factor triggers off the disease in you. So there could be modifiable risk factors like smoking, use of high estrogen containing oral contraceptive pills, hyperlipidemia, hypertension, so on and so forth. So obviously, if there are any, these also need to be addressed. So it's not just about anticoagulation, but all these things need to be addressed. So the first and the foremost is about secondary thromboprophylaxis. What is secondary thromboprophylaxis? That is in somebody who's had an event now, a DVT or an arterial thrombosis. Now, because if you don't anticoagulate them, the risk of a recurrent thrombosis is close to 70% in these people. That's why it is important to put them on anticoagulation. And it has been shown that venous events, there's a risk of recurrence is significantly reduced when you maintain an INR of 2 to 3. Coming to arterial clots and recurrent clots, I'll tell you a bit later in the talk about this. So what are the recommendations when it comes to treatment? If you've made a definitive diagnosis of an antiphospholipid antibody syndrome on a background of thrombosis, the period of anticoagulation is indefinite. For the first event, we have to treat with an INR between 2 to 3 if it is a first event. But if the patient has had a first arterial event, there are many suggestions, and one of them is to say that maybe you have to keep the INR higher between 3 to 4, but then you have to understand that there could also be an increased risk of bleed from anticoagulation here, or even combine the antithrombotic treatment like low dose aspirin along with warfarin, and the warfarin to be given maintaining the INR of 2 to 3. However, if there is events in addition to, if there are thrombotic events despite taking warfarin and the patient is maintaining an INR of 2 to 3, what do we do? Then the first and the foremost thing is to look at patient compliance. Is he taking? Second, are there vitamin K antagonists that they are taking, so that whatever warfarin you are taking, agonists, so that it neutralizes the warfarin that you're taking. There could be many food stuff that patients has to avoid to achieve the correct INR levels. Are they monitoring INR from a standard lab? If all of these are done, then obviously you have to maintain a higher INR or aspirin, as I've said earlier. So that is the way it is done as far as thrombosis is concerned. So what happens to people who have antibodies but have never had any clinical problems? That is, this is more prevalent nowadays when people go for a whole lot of checks, master checks and master checks, and people do a variety of autoantibody checks. Some notorious labs which give reports like almost like a notebook, some 50 reports for 2,500 rupees. I mean, these are ridiculous things that are going on only in India. So what do we do for primary prophylaxis? Primary prophylaxis means that this person has not had any event. So who comes under this group? You have people who are asymptomatic, but they have a high risk APL profile, or patients with lupus. They have other problems with lupus, but have never had any thrombosis, but they're APLA positive. And then you have, people who want to become pregnant, but have never had clinical events, but APLA antibodies are positive. This is, the group where, for example, you're screening for primary infertility, and you look at the antibodies and you find that they have never conceived and you have antibodies. What do we do for such people? For such people, the only treatment that is recommended is aspirin, 75 milligrams daily, and no heparin. Look for reduction of other risk factors for thrombosis, cover them during high risk situations like surgery, postpartum, immobilization, so on and so forth. And who has said that this is what it should be done? These are the latest recommendations from a European group of experts called EULAR, European League Against Rheumatism, which includes people who are all involved in the management of antiphospholipid syndrome, like hematologists, rheumatologists, and others. So how do we manage obstetric APLA? Obstetric APLA is a recurrent pregnancy loss along with positive antibodies. So the first and the foremost thing is a planned pregnancy is important. Send all the 3 antibody profiles. Then also screen for lupus because of the coexistence. Because if you concentrate only on APLA and the patient has bad lupus, you might miss out on the lupus. And once they conceive, antenatal visits should be frequent, especially to monitor preeclamptic toxemia, hypertension, proteinuria, fetal surveillance, especially for placental insufficiency, and uterine and umbilical artery Doppler to assess for the risk of PET or placental insufficiency or fetal growth restriction. So all these are from the monitoring side. How do we screen for lupus? It has been shown in this PROMISE study that if women have lupus, the risk of flare during pregnancy is 12%, which is mild to moderate, and 2.5% have a severe flare. So how do we screen? One is by the clinical features of lupus. Unfortunately, today's class will not allow us the time to go through all that. So if you are in doubt about history of arthritis, rashes, alopecia, mouth ulcers, previous cardiac story, previous strokes, there are a variety of symptoms that can go with lupus, previous nephrological problems, then the best is to refer them to a rheumatologist. Some screening tests that can be done are ANA, when you're doing it by immunofluorescence, is the best, C3 complement, C4 complement, anti-double stranded DNA, and all the routine lab tests. And coming to the prevention, I'll deal about it a bit later. So when it comes to a woman who has had recurrent pregnancy losses and have positive antiphospholipid antibodies, what we call as obstetric APLA, one treatment is obviously, as you all know, it is heparin. But the most important point here is, when do we start heparin? Heparin, low molecular weight heparin, should be started only after confirmation of pregnancy on an ultrasound scan. Along with heparin, we know we all start aspirin. However, the latest recommendations from the EULAR say that aspirin should be started even prior to conception because it's helpful for implantation. If the patient is already on warfarin, then obviously warfarin is stopped because it's teratogenic and switched over to low molecular weight heparin. Now, without doing this, the chances of a successful pregnancy is 30%. If you give aspirin alone, it's about 50%. If you combine it with heparin and aspirin, it's about 70%. And important for those with obstetric APLA, after the delivery, don't think your job is over, because the risk of thrombosis is very high within the first 6 weeks after delivery, and hence low molecular weight heparin should be continued even for 6 weeks after delivery. So how do we deal with obstetric APLA? We divide them into 2 important groups. One is those without any previous history of thrombosis, and the other one is those with previous history of thrombosis. So if you have a primee who's never had any pregnancy complications but has antibodies, then the treatment is only aspirin. And here the recommendation says 75 milligrams should suffice. If they've had recurrent early miscarriages, I mean, the recommendation according to the EULAR is more than 3, but sometimes practically we may not be able to wait till 3. We might start off with the second one. Here you'll have to, especially if it is recurrent, you will combine low molecular weight heparin with aspirin. but the low molecular weight heparin should be in the prophylactic dose. If there is a fetal death, that is, it happens after 10 weeks, or there is an early delivery due to all the other causes I mentioned earlier, once again, aspirin plus heparin in prophylactic doses. However, if a lady has already previous history of thrombosis, you need to give the low molecular weight heparin in therapeutic doses. And the two licensed low molecular weight heparin are enoxaparin and deltaparin. And importantly, when you switch them over from warfarin or acetrom to heparin, it is important to remember that it has to be done immediately after pregnancy is confirmed. Ideally, it should be done before the 6th week of gestation to avoid warfarin teratogenicity. However, we know that recurrent pregnancy losses can be still recurrent despite using aspirin, despite using warfarin, despite using low molecular weight heparin. What do you do when there is failure despite therapy? Now, nobody knows actually what to do. There are some aspects that can be done. The simplest of it is adding hydroxychloroquine. I'll tell you why we should do this. The second one is some people have suggested that maybe you should give a therapeutic dose of low molecular weight heparin in these people rather than a prophylactic dose. The data to support this is very sparse, but in desperate situations, if there is no other big risk of bleed, then yes. Steroids, do they have a role in the first trimester? That's one other question mark. And IVIG, whether it has a role. So all these are experimental because the grade of evidence for this is low, except hydroxychloroquine. Now, when a woman has lupus, the obstetric outcomes are anyway poor right from the beginning when the time they have a diagnosis of lupus. And why is that? That is because menstrual irregularity is there in nearly 53% of lupus women. That is a whopping number. Secondary endometriosis, autoimmune oophorytis, and premature ovarian failure are very well described. And premature ovarian failure in part could be due to a reduced ovarian reserve and AMH. And this could be related to the disease itself. It could be due to the coexisting antiphospholipid antibody syndrome, or it could be due to therapies like cyclophosphamide, high-dose corticosteroids, and sometimes high-dose NSAIDs that are sometimes given in lupus. Men with lupus also have poor fertility. There's a reduction in testicular volume due to the damage to seminiferous tubules and production of anti-sperm antibodies. A lot of these sick patients have an important problem, which is erectile dysfunction that is easily overlooked. So these are the things that the partner, when you look at RPL in a woman, also look at the partner. If the partner is suffering from lupus, look at these things. And one of the important things in lupus determines pregnancy outcomes, and that is active lupus. If the disease is active, very less likely that the pregnancy will sustain. There's an increased risk of prematurity, abortions, and complications. And this is more so when they have lupus nephritis, presence of antiphospholipid, as I said earlier. And sometimes lupus complications are more in the presence of anti-La antibodies, more so because of neonatal heart block, complete heart block that's seen in the baby of Rho positive mothers. I won't deal with this. This is completely a different situation. So poor outcomes that impede successful pregnancies in lupus indicates persistent proteinuria, severe thrombocytopenia, presence of arterial hypertension, previous bad obstetric history. Hydroxychloroquine for lupus is like aspirin for coronary artery disease. If you don't give aspirin to somebody with an ischemic heart disease, you are committing a big blunder or a crime. Similarly, if you don't give hydroxychloroquine to a lupus lady, you are doing a big crime. So many times, a lot of obstetricians I've seen who don't know what drugs are safe, they stop hydroxychloroquine. Sometimes even patients get scared. They assume that all drugs should be stopped in the first trimester. So hydroxychloroquine discontinuation has been shown to have a poor outcome in lupus pregnancies and glucocorticoid use in high doses. However, there are certain situations where you will advise a woman not to conceive at all in the background of lupus. And one of them is pulmonary hypertension, advanced heart failure, severe restrictive lung disease where the FVC is less than a liter, women with active lupus nephritis or chronic renal failure. And once you have treated some of these, like especially renal disease, which has responded beautifully to treatment, how long should you wait? The textbooks say 6 months remission, but personally, I feel very comfortable when women have been in remission at least for 1.5 to 2 years. That's my version. So what do you do in terms of treatment? All lupus patients, when they conceive, should be started on aspirin. And this is more effective if it is commenced when conception is planned. So even before pregnancy, they should start aspirin. And in the context of lupus, the aspirin dose that is recommended is 150 milligrams. And it has been shown that if you give aspirin even before they conceive, it reduces the incidence of IUGR, preterm labor, and PET. What is the role of hydroxychloroquine? Hydroxychloroquine is known to reduce antiphospholipid titers in the plasma of patients who are positive. And that's why we say that one of the therapies where aspirin and heparin have failed, you add hydroxychloroquine. It improves fetal outcomes in lupus-treated patients. It reduces the binding of beta-2-GP1, and we know beta-2-GP1 is one of the pathogenic antibodies. So it prevents its binding to trophoblastic cells. So that's why hydroxychloroquine should be given to all women with a history of lupus, whether they have thrombosis or no. It should be given to all women with refractory obstetrical antiphospholipid antibody syndrome, women with triple antibody positivity. And there are two studies that are currently underway, multi-center studies. One is called the Hypatia study, and the other is called Hibiscus study, which is looking at the role of hydroxychloroquine in this context. So it's also useful to prevent the recurrence of complete heart blocks in families who already have a previously affected child. However, despite your best efforts, treatment failure does happen in 30% of APLA pregnancies. So there is a need for newer therapies. So the last few of my slides will concentrate on where we go when there is an unexplained recurrent pregnancy loss. We are desperately trying to look for a cause because women fail to conceive, they lose regularly. So what do we do? What can we do? Clinically, there is something called non-criteria antiphospholipid antibody syndrome. What does that mean? I've told you about the criteria ones. The criteria ones are the ones who had thrombosis, who had obstetric outcomes, who had positivity. But then there are other manifestations of the disease which might come alone, and your patient may not have had any previous history of thrombosis, major thrombosis at all. And what are those? Some of the important ones is one skin rash called livedo reticularis, because it is prevalent in about 24% of patients. And this is a study called Europhospholipid Project. And the picture that I've put here is an example of how livedo reticularis looks. It's a lace-like mesh or network. Some patients with APLA present as just non-healing skin ulcers. We've had quite a few like this. And once you anticoagulate them, the skin ulcers heal. And one other common manifestation for non-criteria APS is migraine, thrombocytopenia. And the thrombocytopenia, unlike lupus in APLA, generally the platelet count doesn't go very low. It is just about less than 1 lakh. And it can be seen in about nearly 30% of women. And renal thrombotic microangiopathy, that is, there is a lot of microthrombosis of the renal vessels. So they will present with hypertension, proteinuria, and a raised creatinine. And this is one of my patients. My resident Tanmay will remember this patient who he presented very recently in one of our meetings, who had thrombotic microangiopathy in the kidneys. So that is our patient's histopathology slide. However, there are various other manifestations like cardiac valve dysfunction, vegetations, epilepsy, chorea, so on and so forth. So these always look for, and this is mainly for the rheumatologists I'm telling you who are listening to this lecture, if you don't find conventional thrombosis, you're suspecting some moderate to low titer antibodies, look for these unusual manifestations. Now, despite autoantibodies, the three principal ones being negative, there could still be thrombosis. So are there other antibodies that we don't know which is causing thrombosis? So a variety of other APLA antibodies are described, and phosphatidylserine, some labs do it, but the others are all research ones. The clinical relevance is still not known. Maybe in the coming years, who knows, the clinical relevance of these will be disclosed, and then we might even get to test them clinically. So you might find answers in even that 30% of women who did not conceive properly. And generally, obstetricians have a tendency to do a lot of tick box when they look for recurrent pregnancy loss. And generally, in most labs, they have something like called, a thrombophilia screen. And that includes lupus anticoagulant, anticardiolipin, and all the rest of it. And along with that, a lot of other prothrombotic tests are done, protein C, protein S, antithrombin 3. It has been shown that from prospective studies that there is no association between all these protein C, protein S, antithrombin, that is inherited thrombophilia, and recurrent fetal loss. And a study review also showed that if you give them thromboprophylaxis, it does not improve obstetric outcomes. A meta-analysis of almost 8 trials involving 400 patients showed that there is no benefit of using these drugs in patients with protein C, protein S, or antithrombin 3. So also Cochrane review. However, there is an ongoing prospective trial called anticoagulants for live fetuses that is going on in this condition. So till such a time comes, I don't think you should do all these tests. The other common referral that I get from obstetricians is a positive ANA in RPL. So 16% of women with RPL have a positive ANAs. However, the next pregnancy outcomes do not significantly differ from women who are ANA negative. In other words, to say that a mere positive ANA in the absence of clinical features does not make sense. It does not mean anything to us. And hence, the current evidence do not support routinely testing ANA in otherwise healthy women who are being investigated for recurrent pregnancy loss. Thyroid is another favorite of all of us. Anti-thyroid peroxidase antibodies. This has been shown the incidence of these antibodies is high in women of reproductive age group, irrespective of the thyroid status. So it's about 8 to 14%, and majority of these women are euthyroid. There have been recent meta-analysis which showed that there is an increased risk of miscarriage in women who have anti-thyroid peroxidase antibodies, but the association is weak with anti-thyroglobulin antibodies. So the odds ratio is fairly high, 4.2. And this miscarriage was increased even in euthyroid women. So the European Society for Human Reproduction and Embryology, you people are very familiar with this, the ESHARE recommendation. It gives a strong recommendation for screening women with TSH and TPO antibodies in RPL. However, the problem is nobody gives any recommendation on what to do if you find this antibody. Some associations suggest that you should treat them and keep the TSH less than 2.5. One other drug that has been of great interest is vitamin D. And this is of great interest to a variety of people, physicians, immunologists, now even obstetricians, because vitamin D is supposed to be an immunomodulator, and it is known to reduce the beta-2 glycoprotein and probably has an influence on APLA and also on complement activation. So the question is, can vitamin D be a drug to treat recurrent pregnancy loss? A meta-analysis of 7 observational studies and 4 clinical studies showed that women with RPL have lower vitamin D levels than controls. Decreased vitamin D receptors and active vitamin D metabolite expression was seen in decidual and villus tissues of women with RPL. And those women who are vitamin D deficient also had increased chances of having various autoantibodies like APLA, ANA, so on and so forth. And larger number of CD19 B cells and NK cell cytotoxicity in women with RPL with vitamin D deficiency was seen. So, and in vitro experiments have shown that giving vitamin D might to some extent reverse the APL. But the question is whether giving vitamin D will be beneficial to women with RPL is not answered. So also the question about steroids. There is some data to say that adding prednisolone helped in unexplained pregnancy loss in women with positive connective tissue disease. However, a large study more recently did not show any added benefit of adding prednisolone in addition to aspirin. There is an ongoing trial, what I have written here, iLife, that is immunosuppressant for living fetuses, which is ongoing. So till the results of that study come, Steroids should not be routinely used for mere antibody positivity or recurrent pregnancy loss. Most obstetricians are familiar with intralipid, which is a fat emulsion used for parenteral nutrition. And this might benefit by reducing peripheral blood natural killer cell activity. There was only one RCT which looked at it, but it said that there was no benefit in the primary outcome, which was chemical pregnancy. There are many experimental agents that have come up that are being looked at in very small series, one of which is a drug that is very commonly used by rheumatologists called adalimumab for rheumatoid arthritis and ankylosing spondylitis. Small series saying that it improved the live birth rate. Granulocyte colony stimulating factor, there has been some pilot study on this. Finally, what are you going to use? So this is a beautiful summary from your Escher recommendation that if you have recurrent pregnancy loss, the recommended tests are antiphospholipid antibodies, thyroid, and look for uterine abnormalities. The other tests that you should really think are these, and those which are not recommended are other immunological tests and hormonal tests. And when you look at the guidelines, it says not to screen for hereditary thrombophilia, ANA plus minus, insufficient evidence to recommend NK cell testing. Thyroid screening, especially TSH and TPO antibodies are recommended, but the guidelines say there is insufficient evidence to support treatment. Unnecessary tests like homocysteine, thrombophilia, vitamin D, so on and so forth, not to be done at this point in time. IVIG, according to these guidelines, not recommended. Glucocorticoids, not recommended. Heparin or low-dose aspirin is not recommended in women who do not have any antiphospholipid antibodies but have just RPL. So there is a tendency amongst a lot of obstetricians to give aspirin and heparin to every rheumatological disease. I've seen people giving it for rheumatoid arthritis to Takayasu's arthritis. Don't do that. There is a contrary viewpoint from the American Thyroid Association, which has a strong recommendation for thyroxine use with combined autoimmunity and a TSH of more than 4, but a weak recommendation to consider thyroxine in those who are antibody TSH and the TSH is less than 2.5. So in summary, of the various treatable causes, the most evident is antiphospholipid antibody syndrome. Whenever you are using anticoagulation, the therapy should be individualized and evidence-based. Asymptomatic carriers should not be treated. Combined care with a rheumatologist or a hematologist improves obstetric outcomes. And don't forget, you are not God. Despite our best efforts, there are a lot of women who do not conceive. You may never be able to give a cause. If you look at the data on recurrent pregnancy losses, the cause can be put in only in about 45% of women. There are still 55% of women, God knows why they don't conceive. So don't try to be too heroic and give a lot of unnecessary drugs in your enthusiasm to improve your pregnancy outcomes. Thank you very much. If you have any questions, I'm more than happy to take it.
So where do you recommend testing with ANA levels?
ANA should be tested only in people who have connective tissue disease symptoms, not otherwise. There's a question from Dr. Anupama Patil, who says, can you please also tell us, repeat the role of anti-TPO in RPL? So basically what they say is, if the anti-TPO titers are high and the TSH is more than 4.5, then maybe there is a role to play in some treatment. This is controversial. Whereas if the TSH is less than 2.5, then don't treat, even though antibodies are there. But they say that because there is an increased association with miscarriages, you could test so that at least you might get a cause. If not, you don't know how to treat it.
Sir, what is the treatment if anti-TPO is positive? Steroids?
That's exactly what I said just now. There is no role for giving steroids in anti-TPO positivity. Nobody actually knows what to do. The only thing people have suggested is if the TSH levels is on the higher side, give thyroxine, don't do anything.
Sir, what is the safety profile of HCQs in pregnancy, sir? Like we can start from any...
safe. 100% safe. So HCQS, as I said earlier, should not be stopped in pregnancies, especially in lupus patients, because there's a very high risk of lupus flare if you stop.
Thank you, sir.
If anybody has any questions, they can type, or you can unmute yourself and ask.
Sir, I've seen patients who do not have any symptoms of connective tissue disorder, but when we get APLA positive, we do ANA with that, it comes positive. We run the screen, it comes positive.
Yeah.
So what about those cases?
Yeah. So one, you have to understand that autoantibodies are positive in 10 to 15% of normal people. So if we do an antibody test on all of us, some of us at least will be positive for all these. Now, when you do the profile is fairly specific. Even here, it's not the positivity, it is the degree of positivity that is important. So if you find somebody as borderline positive, 1+ positive, we can ignore, especially if they don't have symptoms of that connective tissue disease. And finally, you have to understand that sometimes autoantibodies may be positive for a connective tissue disease many, many years, even before the disease actually starts. I mean, I think Dr. Chaitra or somebody referred a lady to me recently who had anti-Jo1 antibody positive in high titers, in fact, but she doesn't have any features of dermatomyositis or interstitial lung disease, and she's now carrying. So if you remember Dr. Chaitra or Dr. Maheshwari, I don't know who has referred, but I know it's from Garbhagudi. We have only said that we'll keep a careful watch on the patient because there's no evidence to say treating them is going to improve the outcomes. What is the dose of hydroxychloroquine in pregnancy? Generally, the dose of hydroxychloroquine should not exceed 5 milligram per kilogram. So in the Indian setting, majority of the times the dose is 200 to 300 milligrams. We don't exceed 5 milligram per kilogram. Only in patients who have renal disease, we might use a lesser dose, or somebody who's got retinal abnormalities, we might not give.
Sir, I have a patient with rheumatoid arthritis who is keen on conception, sir. So what are the criteria for her to go for pregnancy? Like when she can?
The first important criteria is the rheumatoid arthritis should be under control. Okay, because one, to even be sexually active, if she has painful swollen joints, she cannot be. And the fertility is not reduced in rheumatoid arthritis, so she will conceive irrespective of whatever it is. So the best time for conception, one, she has to be healthy. The rheumatoid arthritis should be quiescent clinically at least for a period of 6 months to a year. Second, she should not be on certain drugs that are used to be treating rheumatoid arthritis. The most important is methotrexate. The methotrexate should be stopped at least 3 months in advance. There's another drug called leflunomide that has to be stopped at least 6 months in advance. Although there are some series saying nowadays that it is relatively safe, but as of now, I would say 6 months. There are some other newer drugs like biologicals. They're called tofacitinib, baricitinib. They should also be stopped at least 2 to 3 months in advance. So the drug profile has to be looked at. Safe drugs are sulfasalazine, hydroxychloroquine, and prednisolone, and azathioprine if you're using.
Thank you,
sir. Sir, thrombosis is arterial or venous? How you will differentiate, sir?
Arterial thrombosis, the commonest examples are TIAs, cerebral strokes, MI, myocardial infarction. These are examples of arterial thrombosis. Venous thrombosis are examples of DVTs, central sinus thrombosis, retinal vein occlusion, renal vein thrombosis, Budd-Chiari syndrome, that is IVC. They are all vein.
Thank you, sir.
Sir, excuse me.
Yeah.
So if a patient she loses like IUD due to severe PE, so next pregnancy, what all the, like how we have to?
P is PET you're saying, or pulmonary embolism?
Yeah, PET.
PET.
Severe PE, yeah. Preeclampsia, yeah.
If you have seen a woman with only severe PET, and if you think there was nothing else and she's at risk, one is to screen for APLA. That's the first thing you should do, because there is a high incidence of, there's a high connection between APLA and PET, which is commonly forgotten. And if there is APLA positivity, then whatever I taught till now, that has to be followed, a referral to a rheumatologist and then advice.
Okay. We have to start her with low molecular weight heparin.
Yeah, so that depends on whether you have antiphospholipid antibody or not. You know that it can be seen only in about a proportion of PETs, about 12 to 13%. The rest are all idiopathic PETs. You don't give heparin and aspirin for all PETs. It's only for those associated with antiphospholipid antibody syndrome.
Okay, thank you, sir.
So what are the criteria for starting the SCQ?
What are the, sorry?
Criteria for starting the hydroxychloroquine?
In the context of antiphospholipid syndrome?
Yes, sir.
Okay. In the context of antiphospholipid syndrome, if they have coexistent lupus or ANA positivity, I will give it. Otherwise, if despite aspirin and heparin combo failure, if they continue to have recurrent pregnancy loss, I will give it. Or if they have a previous pregnancy which had a rho positivity was documented, I will give it. And if this is their second pregnancy and the previous child had complete heart block, I will give it.
Okay.
Any other
So you
question?
just said that ANA, excuse me, sir. So you
Yeah.
just said that ANA positivity. So ANA positivity means if it is a borderline ANA positive, we can,
No,
there's
if
no
they
need to
don't have
start.
any, if it's a borderline ANA positivity with no clinical symptoms, because ANA means it has to be immunofluorescence. There should be an N titer determined for the ANA. A lot of labs don't do the N titer. The intensity of ANA positivity is important. 1 plus fluorescence, 2 plus, 3 plus, all those are very important. So that's why if it is 2 to 3 plus and the ANA positivity is more than 1 in 160, then the ANA is considered significant. Otherwise, it is not considered significant.
So, sir, when we are writing ANA test, so do we have to specify that it has to be done by
Yes. You should
immunofluorescence?
write ANA in bracket IF. Otherwise, labs do ELISA, which is a useless test.
Okay. Thank you, sir.
Sure. Any other questions? There are no questions, host. Do we close?
Doctors, any other questions or can we wind up with the session? I think, sir, they're clear with all the doubts. And thank you so much, sir. That was a very interesting session and you cleared lots of our doubts. Thank you so much.
Sure. Thank you, everyone.
Yeah, thank you. Thank you, doctors. Happy evening. We are winding up with the class. Thank you.